Hi, my name is Dr. Anand Sardesai. I work as a consultant anaesthetist at Addenbrooke's Hospital in Cambridge, UK. I have special interest in regional anesthesia. Today, I'm going to talk to you about anatomy, upper limb blocks, and various approaches to brachial plexus. Motor and sensory innervation of the upper limb is derived from the brachial plexus. Good knowledge of anatomy easily block the brachial plexus. By studying anatomy, we can appreciate the arrangement of the brachial plexus in human body, and this in turn helps us to choose the best approach to blocking the brachial plexus to suit the. When we learn anatomy in medical school or when we read textbooks of anatomy, we are taught so-called normal anatomy. However, normal means most commonly occurring arrangement of structures. This may be seen in less than 50% of the population. Very little time is devoted to teach variation in anatomy. So when we see variation, we think it is abnormal. Here is Captain Spock from Star Trek doing his Vulcan salute. So he is raising his hand with palm forward and thumb extended, and while the fingers are parted between the middle and ring finger. Although some of you will be able to do this very easily, I find it very difficult to do. I guess the arrangement of tendons in my hand is different to you. I guess I'm human and not Vulcan. No two living organisms are either structurally or functionally identical. Even once, if you take two cars of the same make and model, made in the same factory in the same year, you'll find, and if you open their bonnet, you'll find that the wiring is almost identical. However, we're not all made in the same factory. Even though the arrangement of the nerves is similar in our body, it's not exactly the same. So variation is very common. How common is the anatomical variation? Luckily, we are in an era where we use ultrasound. Before ultrasound, we had to depend on anatomical landmarks to determine site of needle insertion. If the patient had variant anatomy, then that resulted in multiple needle attempts before target nerve was found. Now with ultrasound, we don't have to use anatomical landmarks and go hunting for the nerves in the dark. In this talk, we will look at the anatomy at each level of the brachial plexus and look at its significance and how it affects block performance, dynamics, and complications. So let us start by looking at anatomy at each level. This is what the textbook tells us about the anatomy of the brachial plexus. The anterior rami of the spinal nerves C5, C6, C7, C8 and T1 form the roots of the brachial plexus. Roots of C5 and C6 unite to form the upper trunk. The C7 root continues as middle trunk and the roots of C8 and T1 form the lower trunks. These trunks then further divide into anterior and posterior divisions. The posterior divisions of all the three trunks unite to form the posterior cord. The anterior division of upper and middle trunk unite to form the lateral cord, and the anterior division of the lower trunk continues as the medial cord. Cords then give rise to terminal branches. These are some of the major branches from the cord. The lateral cord will give rise to musculocutaneous nerve and the lateral head of the median nerve. Posterior cord will give rise to axillary nerve and the radial nerve, and the medial cord gives rise to medial head of the median nerve and the ulnar nerve. Classic description of the plexus with C5 to T1 nerve roots combining to form 3 trunks, 6 divisions, 3 cords and 5 main motor and sensory branches to the upper extremity is an oversimplification to some degree. In a major study done at the beginning of the last century, they dissected 175 cadavers, and what they found was there were 29 total configurations of the brachial plexus, with 7 configurations seen predominantly. No configuration had more than 57% representation, and 61% of the cadavers that they dissected had right to left asymmetry. After reading this book online, now I feel when I was asked in my final FRC exam to draw a neat label diagram of the brachial plexus, I could have drawn any of these diagrams and I would have still managed to pass. Right to left asymmetry is also what we found when we did spatial mapping of the brachial plexus using 3D ultrasound in Cambridge. In the same subject, you can see how different right and the left side of the brachial plexus is. Brachial plexus often receives contribution from C4 or T2. Brachial plexus is called prefix if the branch it receives from C4 is larger than the branch from T2. In prefix brachial plexus, the branch from T2 is often absent and the branch from T1 is reduced in size. It is called postfix brachial plexus if branch for C4 is absent and branch from T2 is present. The prefixation of the brachial plexus is more common than the postfixation. In this picture, all the superficial layers of the neck are absent. You can see the first rib, also scalenus anterior muscle, which arises from the anterior tubercles of the transverse processes of the 3rd, 4th, 5th and 6th cervical vertebra, and then it descends almost vertically to insert by a narrow flat tendon into the scalene tubercle on the inner border of the first rib and into the ridge on the upper surface of the rib in front of the subclavian groove. You can see the scalenus medius muscle, which arises from the posterior tubercles of the transverse processes of the lower 6 cervical vertebrae. It descends along the side of the vertebral column and is inserted by a broad attachment into the upper surface of the first rib between the tubercle and the subclavian groove. The roots of the plexus arise between scalenus anterior and the scalenus medius muscle. Roots form trunks and divisions behind the clavicle and be posterolateral to the subclavian artery as it passes over the first rib. Trunks and divisions then form cords around the axillary artery below the clavicle. The cords divide into terminal branches in the axilla. If you look at this figure, you can see that the origin of the brachial plexus is quite broad, and then it sort of narrows around the level of the clavicle just on the top of the first rib, and then again in axilla as it branches it spreads out. So it has got an hourglass shape. The significance of this is that it is at its most compact around the clavicle. So a single injection done at this level has the potential to block the most of the plexus. Brachial plexus lies along the line of Crossi. This line starts at the apex of the scalene triangle and terminates on top of the axillary artery in the axilla. Along its course, it passes through the midpoint of the clavicle and also middle of the chest profile and the coracoid process. It was a very useful line to use when nerve blocks were done using just a nerve stimulator, as the brachial plexus was found along this line. However, it is less useful now as we can see the nerves now using ultrasound. Let us see now how we can block the brachial plexus by different approaches. This man needs no introduction, certainly to our UK audience. He's Robbie Williams and he's a famous pop singer. He's striking a pose in this picture, and when I see this as a regional anesthetist, I feel he's asking me how I can block his brachial plexus. So if I do an interscalene block on him, I'll be blocking the roots of the brachial plexus. If I did a supraclavicular block on him, I'll be targeting the trunks and the divisions of the brachial plexus. Cords will be blocked with an infraclavicular block. And I'll be blocking the terminal branches of the brachial plexus proximally if I do an axillary block. And with an elbow block, I'll be blocking these terminal branches more distally. So when you are trying to learn an approach to brachial plexus, there are certain things you would like to know. So certainly I would like to know what it blocks and what it doesn't block. What operations is it good for? What are the contraindications? How do you find the nerves, either using nerve stimulator or ultrasound? And how is the block done? And what are the complications of that particular block? So let us start by looking at interscalene brachial plexus block. So it blocks mainly the upper nerve roots. It misses the inferior nerve roots because they join the brachial plexus more distally. And also the medial part of the arm supplied by intercostal brachial nerve is not blocked. It is a good block to do for shoulder surgery, upper arm surgery or a lateral elbow surgery. It's a bad block to do for forearm or hand surgery. Let us see how we can easily find the brachial plexus in the neck. In this picture, you are looking at the brachial plexus from the side. You can see the subclavian artery crossing over the first rib. The roots of the brachial plexus emerge between the scalenus anterior muscle and the scalenus medius muscle, and then form trunks and divisions behind the subclavian artery. The relationship of the brachial plexus with the artery is very important as it helps us find the brachial plexus in the neck. With ultrasound, the best way to find nerves is by looking at the structure which you can easily identify. Blood vessels, especially arteries, are easy to identify. Imagine this orange to be an ultrasound probe. This is placed behind the clavicle so that a cross-sectional view of the subclavian artery is obtained. In that view, you will see the subclavian artery pulsating over an hyperechoic first rib with pleura visible on either side of the rib and the brachial plexus bunched up posterolateral to the artery. Similarly here, the subclavian artery, posterolateral to it, the brachial plexus, rib underneath, pleura on either side of the rib. Now there is pleura underneath the rib as well. It's just that you don't see it because the ultrasound does not go through the rib. As the probe is moved cephaloid over the interscalene groove, you'll see the roots of the brachial plexus stacking up on top of each other between the scalenus anterior and the scalenus medius muscle. These are the roots of the brachial plexus here. Scalenus anterior in front, scalenus medius at the back. The stoplight sign is a frequently described image during ultrasound-guided interscalene block, referring to the three hypoechoic structures found between the scalene anterior and the scalene medius muscle. It is commonly held belief that these three structures you see are roots of C5, C6 and C7. However, in this study, the authors did 20 dissections of the brachial plexus in 10 embalmed human cadavers and systematically analyzed and measured the roots of C5 to C7 and then correlated their findings with ultrasonographic images on file. Their results provide the anatomic basis to define the stoplight sign as one made of, from cephalad to caudal, the roots of C5, upper fascicles of C6 and the lower fascicles of C6 without any contribution from C7. The important clinical implication is that an injection attempted between what is commonly perceived as the gap between C6 and C7 would actually be an intraneural injection at C6. So, this could potentially cause a neuraxial spread of the local anesthetic or cause damage at C6, neural damage at C6. Anatomical variations occur at all levels of the brachial plexus. In this cadaveric study, they looked at the arrangement of roots at the interscalene level. The commonly described anatomical relationship of the brachial plexus lying between anterior scalene and the middle scalene muscle was found in only 60% of the cadavers that they studied. The most common variation was the penetration of the anterior scalene muscle by the C5 or combined C5 and C6 ventral rami. The C5-C6 may fuse before piercing the anterior scalene muscle, and this was seen in 15% of these cases. In another 13% of the cases, the C5 alone pierced the anterior scalene muscle. And also in 3% of their cadavers, they found that this C5 was lying actually anterior to the anterior scalene muscle. There are other nerves which are important to us, which we can identify while we are scanning the neck. One of them is the phrenic nerve. Phrenic nerve usually arises from the root of C4 with a contribution from C5 and C3. It descends along the anterior surface of the scalenus anterior muscle and enters the thorax, sandwiched between the subclavian vein and the subclavian artery. Many variations of the phrenic nerve have been described. Rather than descending behind the subclavian vein, the phrenic nerve may also pass anterior to it. The phrenic nerve may receive branches from the cervical or brachial plexus or arise entirely from the brachial plexus. Cranial nerves 11 and 12 may also contribute branches. An accessory phrenic nerve may arise from roots of C5 and C6 or from the nerve to the subclavius muscle. This variation is present in about 75% of cadavers. As the phrenic nerve descends in the neck, the distance between the phrenic nerve and the roots of the brachial plexus progressively increases. So higher up in the neck, the phrenic nerve is quite close to the roots of the brachial plexus. As it descends down, it's further away from the roots of the brachial plexus. Other nerves which are relevant to us are dorsal scapular nerve and long thoracic nerve. The dorsal scapular nerve arises from the cervical root 5, C5. It commonly pierces the middle scalene muscle. Long thoracic nerve arises from C5, C6 and C7. Although the root from C7 may be absent and the roots from C5 and C6 pierce through the scalenus medius while the C7 root passes in front of the muscle. This picture shows anterior scalene muscle middle scalene muscle, and the roots of the brachial plexus in the interscalene groove. Dorsal scapular nerve and long thoracic nerve lie in the middle scalene muscle, and these nerves are liable to injury in in-plane approach to the interscalene block. This video shows needle for interscalene block approaching in plane through the middle scalene muscle. Now you can see the dorsal scapular nerve just here in the middle scalene muscle. So the great care has to be taken to avoid injury to dorsal scapular nerve. Sympathetic chain and the recurrent laryngeal nerve are also not too far from the roots of the brachial plexus and can get blocked with interscalene block, causing hoarseness of voice and Horner's syndrome. Shoulder joint is supplied by both superficial cervical plexus and the brachial plexus. Cutaneous innervation of the cape region overlying the shoulder joint is separate from the brachial plexus and is supplied by the supraclavicular nerves which originate from the superficial cervical plexus. Therefore, for shoulder surgery to be carried out solely with peripheral nerve blocks, brachial plexus blocks must be combined with superficial cervical plexus block in order to provide coverage for skin incision and closure. Major contribution from the brachial plexus arises from suprascapular nerve as well as the axillary nerve. Having covered the anatomy relevant to interscalene block, let us look at some of the historical anatomical based and nerve stimulation based approaches to interscalene block. So there are anterior approaches like classic Vinnie's approach and approaches which where the needle is inserted parallel to the cervical spine like the Mears approach, and then there are posterior approaches like Pippa's approach. In Vinnie's technique, the needle is inserted perpendicular to the skin in every plane at the level of cricoid cartilage. So with Vinnie's technique, the needle is directed caudal, medial, and slightly posteriorly. With the parallel technique, the needle is inserted slightly higher up at the level of thyroid cartilage, and the needle is directed parallel to the cervical spine. The advantage of the parallel techniques is that the needle is not directed towards the vertebral column. In Vinnie's technique, there have been numerous case reports of epidural spread or total spinal following interscalene block. This was because the needle missed the target and just went a bit too far in, or the needle entered the dural cuff around the cervical nerve root. The parallel technique is also a useful technique for inserting catheters, as the angle that the needle makes with the nerves is more favorable for insertion of catheter. If you're doing nerve stimulation guided interscalene block, then the response that you're looking for is a deltoid or a biceps twitch. You may see some other muscle responses which help you to redirect your needle. So if you see diaphragmatic twitch, that means you're stimulating phrenic nerve and your needle placement is too anterior. If you see posterior shoulder movement, then you're probably stimulating the dorsal scapular nerve and your needle is too posterior. So in that case, diaphragmatic twitch as well as the posterior shoulder movement act as goal posts. And then what you're looking for is the goal, which is the biceps or a deltoid twitch, by redirecting your needle in the middle. Now the next video, Dr. William Harrop Griffiths is demonstrating nerve stimulation guided interscalene block.
It's not the sort of thing I do, but I am going to feel the lateral border sternocleidomastoid. I'm going to drop my finger down to here, go laterally and feel for the interscalene groove. The groove in this patient is not a huge valley. It is, as it often is, a little dimple just behind external bend. You can see EJ showing up. Scratch and a sting coming up in your neck, and that's coming up just in front of EJ there. Scratch, nasty sting. That's fantastic. Okay, I was a bit anterior, and I found the twitches there. Now there's phrenic. Now that's the patient laughing. Now, can you look at that abdomen? Can you see the phrenic nerve there? Yeah? Now that's anterior to the plexus. I'm going to tuck in just behind that. And there's the plexus. Okay? Now, I'm now going to see if I can really show off and give you dorsal scapula by going a little bit posteriorly. No, that. Now that's dorsal scapula. You may need to move the camera to come in and look just above her right shoulder, this bit here.
You can see it, William.
You can see that? Right, okay. Now, having probed all available nerves in this patient's neck, I will get on with it and find the brachial plexus.
Really good.
I know, that's good, isn't it? So I'm now what I call fine-tuning. I know where it is. Now I'm turning the current down a bit. That's a lovely twitch. Nice and clean.
Turn out a bit, William.
Yeah. Clean biceps twitch, all right, nothing else in there, no phrenic, no dorsal scapula. I'm turning down to do a threshold, 4-8, 4-5, 4-2, 4, 3-8, 3-7, 3-5, a little flicker there at 3-2, going back up again, and there's at 4-6. I'm not going to, still not...
It's a tickly one.
Yeah. That feels good, actually, I like that. Let's go down to do a threshold again, that 3, back up, aspirate and 1 mil, please, Denise. 1 mil, and
In the next video, we're going to see how we can identify the roots of the brachial plexus in the interscalene groove using the ultrasound. So the scan is started behind the clavicle, and our aim is to get a good cross-sectional view of the subclavian artery. So you can see the first rib and subclavian artery pulsating on top of it. The right side of the screen in this video is the lateral side. Now you can see the subclavian artery, the trunks of the brachial plexus lying posterolateral to the subclavian artery. Once we've identified the trunks, then we move our probe Kefalard, tracing the trunks, and then you will see the roots of the brachial plexus stacking on top of each other in the interscalene groove. Once you have identified the roots of the brachial plexus, this is how I do the block. So imagine if this patient is having a block on the right side. The block will be done with the patient supine with about 30 to 45 degrees of head up. I will stand behind the right shoulder of the patient with the ultrasound machine positioned on the opposite side so that everything is easily accessible and visible and I am not twisting and turning. The needle will be introduced in plane. So my aim with ultrasound is to find a picture where you can see the roots of the brachial plexus stacked on top of each other in the so-called traffic signal arrangement between the scalenus anterior muscle in the front and the scalenus medius muscle at the back. The needle is introduced in plane, so it passes through the middle scalene muscle, taking care to avoid the dorsal scapular nerve and the long thoracic nerve. Once the needle tip is positioned posterior to the roots, but not in the belly of the middle scalene muscle, I inject local anesthetic, initially 1 ml, just to see how the local anesthetic is spreading. If it is satisfactory, I inject further local anesthetic in 5 ml aliquots so as to spread the local anesthetic posterior to the roots of the brachial plexus. Often this is enough. If not, I redirect my needle on top of the C5 root. Once the needle is positioned on top of C5, I carefully inject more local anesthetic. The next video shows ultrasound guided interscalene block. Here you can see the subclavian artery, the trunks of the brachial plexus lying posterior lateral to the subclavian artery. First rib, pleura on here. So the ultrasound probe at the moment is in the supraclavicular fossa. So we will move the ultrasound probe cephallard first so that we see the roots of the brachial plexus lying on top of each other, stacking up on top of each other, and then we'll do an in-plane ultrasound guided interscalene block. You can see the roots of the brachial plexus now stacked up on top of each other. Scalenus anterior muscle in the front, scalenus medius at the back. In the substance of the scalenus medius muscle, you will see the dorsal scapular nerve traveling. So when we insert our needle in plane, we have to take care not to damage the dorsal scapular nerve. Needle is then positioned between C5 and the upper fascicle of C6. Local anesthetic is injected posterior to the plexus. At this point, it is important to make sure that you're not injecting actually in the muscle. I've redirected my needle on top of C5 now. I'm injecting further local anesthetic on top. You can see here brachial plexus nicely surrounded by local anesthetic. These are the complications of interscalene block. With the conventional high volume interscalene block, phrenic nerve was almost always blocked. Now, slight modifications of the interscalene block have been described, as well as it has been suggested that a low volume interscalene block will prevent phrenic nerve blockade. Although the incidence may be less, complete avoidance of phrenic nerve blockade is not possible, even with a low volume block or a slight modification of the interscalene block. So if you don't want phrenic nerve to be blocked in your patient, then don't do the interscalene block. Sympathetic blockade occurs and causes Horner syndrome. Hoarseness of voice may occur because of recurrent laryngeal nerve blockade. The other 4 complications, thankfully, are very rare now, but they were reported quite often in the nerve stimulation era, where the needle was inserted based on anatomical landmarks, and for any reason, if the patient had variant anatomy or the landmarks were not correctly identified, the needle was inserted probably too far and caused quite these catastrophic complications. Local anesthetic may enter the spinal canal through different routes. Firstly, it may be injected intrathecally. Secondly, it can go intraneurally, or in some cases, if there is a dural cuff which accompanies the nerve as it exists in intravertebral foramen, if that is punctured and local anesthetic is injected there. In the current era with ultrasound, I think this complication should not occur if the block is done properly using ultrasound. Let us look at the supraclavicular block now. Supraclavicular block is called the spinal of the arm, as a single injection carried out in the supraclavicular area has the potential to produce a rapid onset, predictable, dense block of the entire upper limb. However, this block still can miss C8-T1 nerve as well as the area covered by the intercostobrachial nerve. So it's a good block to do for elbow surgery, forearm surgery and hand surgery. But because it misses the C8-T1 roots, it's a poor block to do for ulnar side of the hand. Let us look at the anatomy for supraclavicular blocks. Trunks and divisions of the brachial plexus are blocked by a supraclavicular approach. In this picture, we're looking at the neck from side. All the superficial structures have been removed. You can see the first rib, scalenus anterior muscle, scalene medius muscle, subclavian artery, and you can see the trunks and divisions of the brachial plexus lying posterolateral to the subclavian artery. With ultrasound, the best way to look for nerves is to look for structure which you can easily identify. In this case, it's the subclavian artery. So the orange structure is the probe that we put over subclavian artery so as to get a good cross-sectional view of the subclavian artery. And then we look for the nerves in relation to the subclavian artery. The nerves lie posterolateral to the subclavian artery. And this is what the picture we are aiming to obtain. So we are aiming to see the subclavian artery lying on top of the first rib with pleura on either side of it, and we're going to see the trunks and divisions of the brachial plexus lying posterolateral to the subclavian artery. If you remember your anatomy from the medical school days, there are 7 cervical vertebrae but 8 cervical nerves. That's because the first cervical nerve arises between the occiput and the C1 vertebra. The second one arises between the C1 and C2 vertebra. The third one arises between C2 and C3. The fourth one arises between C3 and C4. And the fifth one arises between the C4 vertebra and the C5 vertebra, and so on and so forth. So the C8 nerve arises between C7 vertebra and thoracic first vertebra, and the T1 root arises between T1 thoracic vertebra and T2 thoracic vertebra. So the contribution from C8 and T1 to the brachial plexus joins the brachial plexus quite lower down. So the contribution from C8 and T1 root lies quite close to the first rib in the so-called corner pocket, which is the pocket between the first rib, the subclavian artery in the front, and this corner over here. In this picture, you can see the subclavian artery. You can see the trunks and divisions of the brachial plexus, and you can see the rib line inferior to the subclavian artery. The target for needle replacement is this corner pocket. Any local anesthetic deposited in this corner pocket will lift up the brachial plexus and also will surround the contribution coming from C8 T1 nerve roots. So, depositing local anesthetic in this corner pocket results in a dense and complete block of the entire upper extremity. It is important to position the plexus over the rib rather than the pleura, as trying to reach the corner pocket when the plexus is over the pleura may result in a pleural puncture and cause pneumothorax. Simple manipulation of the probe, as shown in the video, results in the optimum position of the plexus over the rib. So you can see the subclavian artery is positioned over the pleura. But what we need to do is just make gentle manipulations of the probe so that the subclavian artery lies over the first rib. Not only we have subclavian artery in this area, but also branches of the subclavian artery. Transverse cervical artery and the dorsal scapular artery are found lying amongst the trunks of the brachial plexus in the supraclavicular area. These branches have to be identified and avoided when doing supraclavicular block. In this study, ultrasound examination of the supraclavicular region was done in 50 healthy adult volunteers. Ultrasound images of the supraclavicular region were acquired at 3 probe positions. In position A, both the subclavian artery and the brachial plexus were on the first rib. In position B, the brachial plexus was on the first rib, but the subclavian artery was on the pleura. And in position C, where the brachial plexus was between the anterior scalene muscle and the middle scalene muscle. And the primary outcome variables was the frequency with which TCA, which is the transverse cervical artery, and the dorsal scapular artery were detected by ultrasound. And what they found was you're least likely to encounter either of these arteries in position A, where both the subclavian artery and the brachial plexus is on the first rib. Now, let us look at some traditional non-ultrasound approaches in the supraclavicular region. So in Kulan-Kampf approach, sorry for my pronunciation, the needle is inserted behind the middle of the clavicle and is angled towards the first rib. And either a nerve stimulation is obtained or paresthesia is obtained, and then local anesthetic is injected. But the danger with this approach is that if you miss the first rib, you're more likely to hit the pleura and cause pneumothorax. Another approach was plumb bob approach. So the needle was inserted lateral to the insertion of the sternocleidomastoid muscle in the interscalene groove as low down as possible, and the needle was directed from antero-posterior direction if the patient was lying supine. Another approach was subclavian perivascular approach, which is like a low interscalene approach. So the needle, the subclavian artery was felt in the interscalene groove as low down as possible, and the needle was inserted posterior to the subclavian artery. So looking at the neck from the side, and you can see the subclavian artery and the trunks and the divisions of the brachial plexus over here. So the needle was inserted posterior to the artery and directed caudal. So this finger is on the subclavian artery in the interscalene groove. Needle is inserted posterior to the subclavian artery. The needle was directed directly caudally towards the toes of the patient with no medial angulation, because medial angulation would direct your needle towards the pleura. This is a video showing subclavian perivascular block being done.
We're looking at the right side. Under the skin here is the first rib, and the first rib is effectively, it is at its most lateral part there. So it is effectively running in an antero-posterior direction just at that point. And of course, this is the point at which the nerves are coming out from the neck and moving down towards the axilla along Gross's line. Now the implications of this are, is first going to feel for the groove between the interscalene muscles.
Just lift it up off the pillow.
That's it. And you can see beautifully the sternomastoid there. As he relaxes down, her fingers land up on the anterior, the belly of the anterior scalene muscle. And then by gently rolling backwards, feel a very slight dimple of the interscalene groove, which some of you, I hope, will have already felt either at work or in the workshops. But now we move down to the lowest point at which we can feel that groove. And Kim's finger is now, this is important, these short beveled needles are a bit uncomfortable going through the skin on their own, so using a 25 gauge or even smaller if you can get hold of them to do an intradermal wheel is important. And only intradermal, not even. Now this is a right-handed, this is a right-sided block. Now this may be difficult for people who are very right-handed, which I am. But even I, right-handed though I am, have learnt to have the needle in my left hand. Now, if twitching above the elbow is completely useless for the success of this block, if you get finger flexion, then my success rate is 98%. Finger extension, slightly less, but it's still in the 90s%. Wrist flexion is about 90. Now, can you just see the wrist beginning to twitch? I think you can see that, but we haven't got. Now you can see that. Can you? I tell you what, just home in on the hand of it, which you feel, and give them a better view of what's happening there. Yes, that's still more wrist.
So the response that you're looking when you're doing nerve stimulation guided subclavian perivascular block is a finger flexion.
We're looking at the right side.
Now, if you're doing ultrasound guided supraclavicular block, this is what I do. So I imagine the patient is having operation on the right side. So I will be standing on the behind the right shoulder of the patient. My machine will be on the opposite side. So again, everything is in line, and I'm not twisting and turning, and I can see everything happening in front of my eyes. Needle is then inserted in plane. My aim is to position my probe over the subclavian artery so that I get a good cross-sectional view of the subclavian artery, and the trunks and the divisions of the brachial plexus are lying posterolateral to the subclavian artery. So that's the artery, first rib over here, brachial plexus, pleura underneath. Needle is inserted in plane. My initial aim is to inject local anesthetic in the corner pocket, as we described before. And when you inject local anesthetic in the corner pocket, the brachial plexus is lifted superiorly. Then I withdraw my needle and redirect it above the brachial plexus. Once it is above the brachial plexus, I will deposit local anesthetic above it, and then I will redirect my needle to go to the middle of the plexus, taking care I'm not impaling any nerves. So I'm doing this block with the patient awake, so he can tell me if I'm too close to it. Once the needle is positioned in the middle of the plexus, I will inject some more local anesthetic. This video shows ultrasound guided supraclavicular block being done. So you can see the subclavian artery, first rib, and the brachial plexus lying posterolateral to the subclavian artery. I'm using color Doppler here to see if there are any other arteries in the vicinity of the brachial plexus. Needle is inserted in plane. Very important to visualize the whole of the needle. Initial needle placement is in the corner pocket, and I'll inject some local anesthetic so as to lift the brachial plexus superiorly. Needle is then redirected above the plexus. It's important to withdraw the needle out of the muscle. If you try and manipulate the needle while it's still in the muscle, you will not be very successful. Always see the whole of the needle. Now let us look at the complications of the supraclavicular block. Now you're too close to the pleura, so there is a small risk of causing pneumothorax. But as long as you see your needle in its entirety and you position your artery and the brachial plexus over the first rib, then the risk of pneumothorax is quite low. You are injecting quite close to a blood vessel, so there is always a theoretical risk of puncturing that blood vessel and causing intravascular injection. It can cause Horner syndrome and it can cause phrenic nerve blockade as well. Let us look at the infraclavicular approach to brachial plexus now. It blocks the cords of the brachial plexus. It misses the axillary nerve, so it's not a good block to do for shoulder surgery. It's a good block for elbow, forearm or hand surgery. It's quite a useful block to do because it avoids the important clockwork in the neck. There is a less risk of pneumothorax if it's done properly. It can be done with any position of the neck. So for example, if the patient is not able to move his neck at all, you can still do the infraclavicular block. In the infraclavicular area, the brachial plexus is still quite compactly placed. So a single injection has the potential to block most of the plexus. And there is a less risk of phrenic nerve blockade with infraclavicular block. Looking at the anatomy, we're blocking the cords of the brachial plexus as they're positioned around the axillary artery. We're looking at the cross section of the chest here. This is the front and that's the back. You can see the scapula here at the back, cross section of the scapula. This is the front of the chest wall. You can see the pectoralis major muscle here, pectoralis minor muscle, that's the clavicle, that's the subclavius muscle, the coracoid process of the scapula, and you can see the axillary artery, axillary vein, and the cords of the brachial plexus, which are arranged around the axillary artery. So when the probe is placed below the clavicle to get a good cross-sectional view of the axillary artery, so again we're looking at the cross-section of the chest, that's the position of the probe. So what you will see is you will see the pectoralis major muscle, shadow produced by the pectoralis major muscle, shadow produced by the pectoralis minor muscle, axillary artery, axillary vein. So that's scaphoid and that's caudal, and then the cords of the brachial plexus around the axillary artery. Axillary artery here, cords of the plexus around here, pectoralis major, pectoralis minor, that's scaphoid, that's caudal. So these are the slides courtesy of Dr. Sembi. So when the probe position is over here, this is what you will see. You'll just see the muscles moving the probe laterally. You'll see the artery now and the pectoralis major and minor muscles on top. Moving it further laterally, you will see the artery with the cords of the brachial plexus around the artery. Position of the cords around the artery is quite variable. In this MRI study, they studied 20 volunteers and to see the distribution of the cords around the axillary artery. So if you consider the artery to be the center of the clock face, then the cords are located between 3 o'clock and 11 o'clock position. But the position of the cords itself is quite variable. So you can see here the distribution of the lateral cord around the artery, posterior cord around the artery, and the medial cord around the artery. But the cords will lie between 3 o'clock position and the 11 o'clock position. Some of the traditional infraclavicular blocks, approaches to the infraclavicular block using nerve stimulation. So the first one is coracoid approach. So in this approach, the coracoid process is felt and the needle is inserted 2 centimeter medial and 2 centimeter caudal to the coracoid process. Needle inserted vertically down This is a vertical infraclavicular approach to the brachial plexus block. Point 1 is suprasternal notch. Point 2 is the anterior acromion, and the point 3 is the midpoint between point 1 and 2, and the needle is inserted vertically downwards immediately underneath the clavicle. So if I'm doing the block on the left side, I'll be standing on the left side. The machine will be in front of me. So again, everything is in line and I'm not twisting and turning. The needle is introduced in plane. So you can see the whole needle as it approaches the plexus. So I'm hoping to see pectoralis major muscle, minor muscle, axillary artery, and the cords of the brachial plexus around the artery. Needle is introduced in plane, and I'm hoping to position the tip of my needle posterior to the axillary artery and deposit local anesthetic posterior to the axillary artery to produce a double bubble effect. So the first bubble is the artery and the second bubble is the local anesthetic. In this video, you can see ultrasound guided infraclavicular block being performed by Dr. Barry Nichols and Dr. Susan Crone. Needle is inserted in plane. You can see the needle approaching in plane, and the needle tip will be positioned posterior to the artery. And the local anesthetic is injected posterior to the artery. A tip for making life easier when doing infraclavicular block: you will see in the picture above, there is not a lot of space between the probe and the clavicle. Now I would like you to imagine your hand as an ultrasound probe, place it underneath the clavicle as lateral and as close to the clavicle as possible. Now there is no place for you to introduce your needle. Now abduct your arm as shown in the picture below, and suddenly there is a lot of space between the hand and the clavicle. So the clavicle has disappeared like the escapologist Houdini. Now you can insert your needle quite easily, and it will be quite parallel to your probe, and so you can see the whole of the needle as it approaches the artery. Now again, there is a risk of pneumothorax with infraclavicular block. It can still cause sympathetic blockade. Phrenic nerve blockade is still possible. It's rare to cause recurrent laryngeal nerve blockade, and also there is a risk of vascular puncture. Let us look at the axillary approach to the brachial plexus block. In axillary approach, we are targeting the four main terminal branches of the brachial plexus, mainly the ulnar, median, radial, and the musculocutaneous nerve. Now, it doesn't miss any branch from the brachial plexus, but it will still miss the intercostobrachial nerve, and so you may still have a spared skin area on the medial aspect of your arm. It's a good block for forearm and hand operations. It's not so good block to do for any operation above the elbow. So as I said, is you block the terminal branches with the axillary approach. Now in this you can see the cross section of the arm. You can see the coracobrachialis muscle, the biceps brachii muscle, and the cross section of the humerus. You can also see the axillary, so-called axillary sheath, and the neuromuscular bundle comprising of axillary artery and the vein. The three branches of the brachial plexus, mainly the median, ulnar, and the radial nerve, lie in this neurovascular bundle surrounded by so-called axillary sheath. The fourth branch, which is the musculocutaneous nerve, does not usually lie close to the neurovascular bundle. To do a nerve stimulation guided axillary block, patient lies supine with arm abducted. Operator sits in front of the patient like this. Axillary artery is felt as high as possible. After giving local anesthetic to the skin, the needle is inserted, firstly superior to the artery, to stimulate the median nerve, which will be seen as finger flexion. Needle is then redirected to stimulate the musculocutaneous nerve, which will be seen by biceps stimulation. Needle is then directed underneath the artery to stimulate the radial nerve, which will be seen by finger extension. And lastly, the ulnar nerve is targeted, which will be seen as ulnar side flexion of the fingers. Single shot axillary nerve block is not done because the local anesthetic doesn't block all the four nerves with just one injection, and musculocutaneous nerve has to be blocked separately. Usually 2 out of the 3 nerves which lie in the axillary sheath are blocked, and the musculocutaneous nerve is blocked separately. Let us look at the ultrasound findings in the axillary area. So with the patient lying in this position, if you put the probe as high as possible in the axilla so as to get a cross-sectional view of the axillary artery, you will see the nerves lying around the axillary artery. Now, the position of the nerves around the axillary artery is quite variable, and it also depends on the position of the arm. Now, in this ultrasound study, they divided the area around the axillary artery into 8 sectors, and then they looked at the position of the nerves in relation to the axillary artery in these sectors. And what they found was the median nerve was found in sector 1 and 8. So in front of the artery, closer to the skin. Ulnar nerve was seen in sector 2. So again, but that is inferior to the artery. The radial nerve was seen in sector 3, which is inferior to the artery, but also posterior to the artery. Again, but these nerves can lie in a quite variable position. So this is where you may find them more often, but doesn't mean they'll always be there. The musculocutaneous nerve is quite variable. So you can see it between coracobrachialis or biceps muscles. You can see it in the coracobrachialis muscle. You can see it as a part of the median nerve, or you can see it quite close to the axillary artery. So again, the position of the musculocutaneous nerve is quite variable. So in this video, Dr. Nigel Bedford and Dr. James French are demonstrating to us how to do ultrasound guided axillary block. So the position is such that everything is again in line, and so they're not twisting and turning, and everything is happening in front of them. So a good cross-sectional view of the axillary artery is obtained, and then the nerves are identified around the artery in relation to the artery. Local anesthetic, needle is inserted in plane, and then the local anesthetic is injected around all the 4 nerves. So initially they're targeting the median nerve. So the needle is positioned between the median nerve and the axillary artery. The video is speeded up slightly. Hydrodissection is done so that the local anesthetic is lifting the median nerve up now, and there's a space created between the artery and the median nerve. Now the local anesthetic is injected underneath the ulnar nerve. That's the ulnar nerve, that's the median nerve. Local anesthetic is injected superior to the median nerve. Now needle will be directed over top of the artery towards the radial nerve. Local anesthetic is injected superior to the radial nerve. Now the needle is redirected underneath the artery to reach the inferior pole of the radial nerve. That's the musculocutaneous nerve, which is the last nerve that they are blocking. So the axillary block has many advantages. The nerves are quite superficial. It's a good block to do in slightly high BMI patients. The risks are minimal. The major risk is of vascular puncture, but there are no important structures like you will find in neck. The disadvantage is you have to find 4 nerves and block the 4 nerves, and it may need multiple injections for the block to be fully effective. And again, it's a block done below the shoulder, so if you are doing a shoulder operation or anything about that, then it's not very useful. Elbow blocks target the terminal branches of the brachial plexus more distally, like median nerve, ulnar nerve, radial nerve, and also you can block certain cutaneous nerves at the level of elbow, like medial cutaneous nerve of forearm and the lateral cutaneous nerve of forearm. The elbow blocks are usually done to supplement a more proximally done block. So let's say you've done supraclavicular block, but the ulnar nerve is spared. In that case, you can block the ulnar nerve more distally. Some people do it to provide analgesia. So they do an anesthetic block, proximal anesthetic block, using a short-acting local anesthetic, which will be effective for 3 to 4 hours, and the surgery can be done. But then they do peripheral nerve blocks, as in like the nerve blocks at the level of elbow, using a longer acting local anesthetic, so that will provide analgesia for a longer duration. Elbow blocks are not done on their own because most of the hand operations, the tourniquet is used, and the area for the tourniquet is not made numb by doing elbow blocks. Now This is just for academic interest because all these anastomosis which are between median and ulnar nerve are motor anastomosis, not sensory anastomosis. But just for completion's sake, I have listed them here. Similar anastomosis are found in the hand as well. This is the dermatomal distribution of various nerves. From the back. So which block to do for which surgery? So I tend to do interscaling block for shoulder surgery. I do elbow, I do supraclavicular block for elbow, forearm or hand surgery. Infraclavicular block, again similar to supraclavicular block. If I need to put catheter for any reason for post-op analgesia for elbow, forearm or hand surgery, I tend to do infraclavicular block because the infraclavicular block, the area is not very mobile, so you can put a catheter there and the catheter won't fall out. I do auxiliary block for forearm or hand operations. Elbow blocks are done usually as adjunct to general anesthetic or topping up a more proximally done block. So I would like to thank RA UK for allowing me to use the videos. There are two videos which we've used, one for infraclavicular block and one for axillary block, which are courtesy of RA UK, and I'm thankful to Dr. Barry Nichols, Susan Crone, Nigel Bedford and James French for those videos. I borrowed some slides from Dr. Herman Sembi and acknowledged them in the presentation. I would like to thank Dr. Herrick for providing me some of the pictures. Thank you very much for listening.